Okay. Order, order. Welcome to today's session, which is a pre-appointment hearing for the new chair for NHS England. Welcome to the first session with us, Dr. Penny Dash. Thank you so much for coming, much appreciated. I'd like to start, please, by having the first question from Paulette Hamilton.
Good morning, Penny, and thank you, Chair. My first question, Penny, is after reading your CV and you talked about health systems that you've supported around the world to deliver improvements, and you've also talked about supporting major reform programs in the NHS over the last 25 years. How do you feel this experience will assist your chairing, considering things are changing so fast? You're looking at devolution, you're looking at things being broken up, you're also looking at decentralisation. How do you feel that will assist your new role as chair?
Do you mean how will the things I've done in the past assist?
Yeah. Absolutely.
Well, first off, good morning, and thank you for inviting me along today. So very pleased to be here. I've done a lot of things, as I said, in quite a lot of places, but I'm continually learning. And I think that's one of the things that keeps me going, keeps me energised and so on. And I'm continually learning because it's a continually changing world. And exactly as you say, the world is changing at the moment. It's changing very quickly, all sorts of things happening, many things that probably none of us can fully predict into the future. So my general approach is to say, where are we now? I come into any role or into any place, any organisation, and say, what's the starting point? We're very fortunate in healthcare in this country. We've got lots of data. We've got generally quite a lot of cohesion about what are we trying to do. And we've got lots of thoughts and ideas and experiences about what are some of the potential things that we could be doing. As well as, I think, a lot of people who are interested in looking at what's happening in other parts of the world, as well as what's happening in other industries, other parts of our lives.
So let me focus you a little bit then. You've talked, your CV's excellent, talks about all the wonderful things you've done around the world. But in the UK, you seem to have centralised predominantly in London and the surrounding areas. And I'm from Birmingham, and some of the people here are from further afield. The other bit of my question is, how well do you understand the challenges the NHS is facing delivering in other parts of this country?
Okay. So while my employed roles have been largely in London, my work that I've done, partly in consulting, partly in some of those roles, has very much been around the whole country. So I think a bit as I put in there, I've worked in all of the 7 NHS regions. I've worked in most of the current ICS footprints. I've done, actually Birmingham is a place that's a bit of a gap, as I said to you, so I have been reading up on that. I've done a lot of work in Manchester, I've done a lot of work in Dorset, and I say those deliberately because they're very different parts of the country with very different infrastructures. Done quite a lot of work in Hampshire and actually in the Isle of Wight. Done a lot of work in the Midlands, across Bedfordshire, Milton Keynes and so on. I come from Stoke-on-Trent, started my career working there as a night nurse in the hospitals there, and actually did some of my medical school training in Stoke, and then went on and did quite a big piece of work following mid-staffs to look at work across
my other colleagues
area.
will dig deeper, but could you give us an example, before I ask my last question, of something you're really proud of that you've done across?
Yeah. I think one of the proudest things I've done was the work on stroke care. So I started off working in London, doing a lot of analysis of the quality of stroke care. A lot of my work has started with quality of care. That's one of my big passions. Happy to talk more about that. Currently doing some work on that, as you may know. But the stroke work started by looking at quality of care. We looked at all 31 hospitals in London. We looked at the quality of care, of stroke care in all those 31 hospitals in London. Did a lot of work with leading clinicians, working in stroke units in particular, but also in primary care and in social care, and came up with some proposals that were then implemented in London with a significant improvement. So saved, the estimate, latest research says around 96 lives a year were saved, but also far more morbidity from that. And then I worked with the central team to take that across the country. And we then went to every part of the country, I had a very memorable piece, which I've referred to because it's really stuck there, and this is from about 10 years ago or more, which happened to be in Birmingham, with a representative group from society. And there was one lady there, quite elderly lady, and she said to me, I was presenting because Aradazi was leading some of this work, he couldn't go, so I was presenting it. And she said to me, how did you let this happen? That variation in quality of care. And that's always stuck with me. And so from that, really had this strong passion and energy to take that work that had happened in London around the rest of the country. And indeed it did happen, and we now have some excellent stroke care across the country. Still needs to improve because the treatments for stroke care now have evolved and moved on and so on and so forth. But that would be an example of something which very much did across the
So
country.
moving on, Penny, in your CV again, because this is what I am going by, you have a small number of digital healthcare startups, advisory work, that you do advisory work, you've got 2 venture capital organisations. I know you've said you will give some of those up,
Yeah.
but what I'd like to do is, do you think it's appropriate to continue to hold some of the other investment, the other things that you're not giving up, and continue your involvement, especially with Cambridge Health Network, which is currently co-chaired by yourself. How do you see your relationship with Cambridge Network changing, and could it not be seen as a conflict of interest?
Yeah. So on the digital startups, so I have invested in some of those, small amount, but I've still invested in them. So I've gone through those. I've gone through them with Department of Health and Social Care. Ultimately, the Permanent Secretary will take a view and so on and so forth. And I'm very happy to divest any of the ones that I feel, they feel are a conflict. So, you know, I'm with you. I don't want there to be any perception of conflict of interest. So I've agreed with the department that we look at each of them individually, and I divest my ownership stake of any of the ones that we feel are close. Some of them, like one of them is a clinic in Kenya. I don't think that is a conflict. So there's a bit about going through some of those. In terms of the Cambridge Health Network, I think that's an interesting one. So I co-founded that 20 years ago with a colleague. It's a really, we have lots of fantastic speakers. We've actually got Andy Burnham coming to speak tonight up in Manchester, so I'm heading up there. He's going to speak about some of the work they're doing on employment and health and so on. And it's a great way of staying connected. So through the speakers and through the people who come along. At the moment, I do get paid for my time in setting up those events. I'm very happy to step back from that. I'd still like to be able to go to the events and to participate and so on. But I'm very happy, and I've discussed that with my co-chair, that I would move away from any remuneration to avoid any conflict of interest.
Thank you for that, Penny. And can I hand back to the chair?
Thank you very much, Andrew George.
Thank you very much. Your comments about the 10-year plan and the 3, which obviously isn't published yet, and the 3 shifts. You've been critical about lack of progress that has been made with regard to the those 3 shifts. Obviously, they've only just been announced, but there's been an underlying, if you like, desire to achieve those three shifts. I mean, they are unarguably desirable, shifts. So with regard to, for example, the shift from acute hospital care to the community. I mean, what do you see as the primary impediments? I mean, given that it's been a mantra that's been going on for some time, what do you see as the primary impediments to actually achieving that kind of shift, and what needs to be unblocked?
Yeah, it's a very good question. So I think there are a few. One is, as many GPs would say at the moment, there's quite a bit of frustration amongst the primary care community, and the primary care community is obviously much wider than GPs, but there is frustration around levels of investment in that. And if you can look at what's happened in terms of the money over the last 5 years, the last 10 years, we have ended up spending more money in the hospital sector than in the primary care sector and the community sector. And I think that needs to be reversed. Obviously can't do that overnight, but slowly over time that needs to happen, and we need to become more in line with other countries that we would probably aspire to look a bit more like, particularly the Nordic countries, for example. So there's definitely a bit about changing some of those investment patterns and doing that. And of course that is not straightforward to do, and that's going to require quite a lot of changes, both in terms of I don't particularly like the term out of hospital, but in terms of that local care, as well as in terms of the hospital-based care. So one thing is changing the patterns of investment. The second bit is around redesign of that local care. And so there's a lot of talk at the moment about neighbourhood care, integrated neighbourhood teams and so on. And to a degree it means different things to different people. I think there will be more clarity on that will come out through the 10-year plan. But this concept of having multidisciplinary teams that work effectively together, where that is working well across the country, it's really impressive. And there are some fantastic examples in this country of that already happening. So there's a bit about making that more common, taking the best of the rest. There's a big need to do more of that, and really helping people to see what are some of those examples of best practice care, and to work out how do they start to implement those locally. That does require then a whole host of changes to workforce planning, to estates planning, and so on and so forth, as well as, which I'm sure we'll come on to, some of the productivity opportunities, particularly in the acute sector.
Right, but you know that the pressure at the moment is very much on acute care, with substantial delayed discharges, corridor care, ambulances queuing outside the emergency departments. And there'll be a lot of resistance to any suggestion that the leadership of NHS England is going to be withdrawing still further resources from the acute sector. So don't you think your leadership will require pressing the case for, if you like, double running at both ends for a transitional period to achieve these kind of outcomes?
Yeah. So I'm very aware that this is challenging, and I'm also very aware that there are limited funds. So it's not easy to say we're going to double running at the moment. So we do have, those are real constraints. At the same time, if you look across the country, we do have big differences in terms of, first of all, how many people turn up at the front door of a hospital. Big differences across the country. So again, how do we take what's happening in some of the better places and seek to replicate that? That's not about stopping people going to hospital, deliberately. That's about providing better care so they don't need to go into hospital. So there's a piece at the very front door. There's quite some really interesting examples of then looking at what happens when people, for example, particularly people with long-term conditions and so on and so forth, do fall sick. And some very different models again around the country of that rapid response services, bringing together community services, social care services, ambulance services, paramedics and so on, to intervene early and find alternatives to hospital admission. There's then some work which I think is much needed, looking at flow through hospitals. Many people talk about that, speak to a lot of chief execs around the country, lots written on it. How do we really get back to some of the flow, which was better, I think fair to say, 10 years ago, through A&E, through the rest of the hospital, and then there's the discharge element, and how do we make that smoother and easier, which I'm sure I'll be asked, so I'll say it now, isn't just hospital versus social care, it's both. We've got to get the whole bit working better together.
Okay. Challenges ahead, indeed.
Lots of challenges.
Could I move you on to your past experience and an area of political contentiousness that has certainly bedevils debate here, and that is the role of the private sector. I noticed that you've had 19 years in McKinsey in the past, and I just wondered to what extent from that experience you believe that, one might say that that's the dark side, coming from the dark side into the NHS. That I wonder to what extent you recognise the potential risks of the role of the way in which the independent sector might interface with the public sector. Do you think that it can be managed in such a manner that that it doesn't simply allow the private sector to cherry pick the profitable bits and to leave the NHS with the difficult stuff.
Yeah. So
to put it bluntly.
Yeah. No, but absolutely spot on question. So first off, just to reiterate again, I put that in the questionnaire, but the concept of a single payer funded through taxation is a fantastic asset for us. And I say that having looked at other countries, and indeed, if you go to many other countries in the world, they can only dream of having a concept where you have that single payer able to take lifetime risk for a population, able to balance risk across such a large population, able to use data, concepts of the registered list that we have, and so on and so forth. So that the funding, as it were, if I look internationally, if I look at all the data and all the analysis, is an excellent model, and we stick with that. I'm happy to say that. In terms of the provision, there is already a lot of private sector provision in the NHS, and everything from, of course, GPs are private providers. We've got private provision of all the scanners and all the bits of kit and so on and so forth. So there's already a lot of that, and I do think I'm not an expert in procurement, but I certainly, if I look and read about that, many people talk about opportunities for better procurement of all of those things, from bits of kit and so on and so forth, drugs, and the list goes on. When it comes to specifically what you're referring to, so bringing in private providers to provide different types of care, like cataracts being an obvious example, or hip replacement and so on. Yep. So where there is capacity and there's a waiting list, I think in some ways the pragmatic bit is to use it, but the crucial bit is, exactly as you say, is to make sure that you're paying an appropriate price for the level of service provided. And therefore that means getting the tariff right, and it means getting the procurement right, and it also means getting the contract right, and it means getting the contract assurance right, and all of those bits. We are in a fortunate place now in that we've got lots of data. We've got way more data than we've ever had before. I think there is a real ability now to actually have far more variation in tariffs to take into account case mix. That would be true in terms of money flows around the NHS as well as into private providers. And I think if we could do that much more effectively, that would negate the concerns that you referred to of the cherry picking.
So I mean, if it's almost a parallel to the question that Pauline was asking earlier, that in relation to those providers that have a foot in both camps, that are both providing elective care in the NHS, but also providing private care. I mean, you think that can be managed? I mean, there's certainly a lot of unease within the system about how that is currently kind of handled and managed, so, both ethically and in terms of how one assures that the public sector is properly protected. Yeah.
So I think we've got to have a robust tariff system, robust contracting, and robust assurance. And certainly the latter point is something I've been pushing within where I am at the moment, within North West London, been pushing on that. How do we know that we're getting what we paid for?
Okay, thank you very much. Thank you.
Thank you very much. So you mentioned social care, so I'll take you up on the suggestion that we should ask you a bit more about it. How do you see the role of social care in helping to deliver what the NHS priorities should be moving forwards?
So social care is clearly a critical element, particularly with an ageing population and people with more complex needs and so on and so forth. I think there's a real opportunity for more joint working. There are some fantastic examples around the country, some in North West London as well. But one of the things is, should I be appointed, I'm really keen to go and see what is happening in different parts of the country, because I hear a lot about it. I haven't yet witnessed all of that, but certainly there's a lot of talk about some really fantastic examples of joint working across, not just across the NHS and social care, but also wider aspects of government, voluntary sector and so on. So I think there's some good work already happening, say that I'd like to see, particularly looking after people proactively, preempting care and so on, preempting needs. I mean, even in my own patch, we've got things like work on sort of early frailty, supporting simple things like going into people's homes and making sure there's a rail and that there aren't rugs to fall over and so on and so forth. So there's a lot of work to be done there. I think there's opportunities around joint teams. Many people talk about things like having social care staff going out to visit people in their own homes, and then you've got the district nurse coming half an hour later, and could they do more joint working there and so on. So I think there's a lot of opportunities there. Then there's, that's looking more at domiciliary social care. I think in terms of home-based social care, particularly care homes and so on. I have been, as you probably know, been doing this work looking at the role of CQC and now looking at the wider quality landscape. I think there's opportunities to get more data in terms of quality of care and social care.
And what specifically in your role? I mean, what you're talking about is the wider landscape, and this committee is very interested. In fact, we've got an inquiry on it.
Yes.
But what your role specifically and what you personally would do to help to bridge those gaps that you're describing, what would that be?
So I talk quite a lot about this principle of empower and enable. So empower means, I think a lot of that work is down to local systems. I don't see it as my job to go and tell local systems what to do. I think, I do see it as my job to make sure we've got high calibre, capable leaders in every system. But then I think it's up to those local systems to work effectively together. But I do think there are things we can do from the centre to enable that local working. Like, for example, and I, note Ben was pushing Julie and Kelly in the last Health Select Committee on some of the modelling work. I think that's the sort of thing I would like to see more of. I'd like to see more analysis of where are those opportunities, the things I've just referred to. What could that look like? What would the opportunities be? What are the different options for what we could be doing and so on? I think that's the work that we could do more of once nationally, rather than have each local system replicate different pieces of work. So that's setting out some of the principles, doing some of the modelling analysis behind it, asking questions, very keen on this, trying to work with each system in a more collaborative way.
And you feel that's not happening currently?
Yes.
Well, we're trying to get to the number because how is it going to be different under you?
So I like the principle of board to boards, which you might have heard a few people sort of talk about. The concept that what I would like to do, these are aspirations, and obviously I haven't started yet.
We're after
and obviously there's
today.
A new chief exec now, so there's a whole sort of moving parts. But what I'd like to do is move to a world where the centre isn't sitting in some centre, be it in Leeds or in London, but is out there. And we're out there with every bit of the country, almost saying, how can we help? Now, we have an assurance role, clearly, as well, so can't let everyone go off and do completely wacky things. We've got to make sure that this is moving in the right direction, and we are going to have a 10-year plan, and so on and so forth. But what I'm keen to do is to have this as a dialogue, because the benefit of being in a national role is you can see these different things from around the country. You can invest in, say, doing some analysis, doing some thinking, doing some modelling work and so on that could help people locally. And I'd like to build a model whereby we're having challenging conversations, show us your plan, be clear what you're trying to do and so on, and not quite sure you're doing enough here and you're not doing enough there and so on. But also, this bit is great. Can I take this bit and take it to other bits of the country and use that as a best practice example? So that's the kind of ethos.
Thank you. So you told us that, and we don't disagree, aligning the NHS England against the functions it's required to deliver will involve, in, I quote, a major turnaround of one of the largest organisations in the world. You've spoken a bit about your vision there, but I'm curious about the roles you've had in the past. How this is a massive job.
Yeah.
This turnaround is huge.
Yeah.
Can you give us concrete examples of where you in previous work have made changes this large, or at least approaching this large? Because this is its own unique challenge, I accept that. But point us the way. What's your record of delivery before you got this job?
Yeah, so I think exactly as you say, you would be hard pushed to find something of this scale and magnitude anywhere globally, really. And I think we do need to recognise that. So the things I'm taking a bit of hope from are, first off, is I'll apologise in advance for coming back to this, but I have done a lot of work in a lot of systems, including across the whole of this country, and in other bits of the world with not as big as this, but started
Can you
certainly
be
in the tens of
specific?
millions.
Other bits of the world, which, when, how?
Well, I referred in one example to doing some work in Malaysia, just as one example, population of 32 million. But all of the pieces of the work start with what does the population need? We have to always start with what does the population need. And the great thing here is we know, more or less, of the population. We've got lots of data on health needs. There's obviously been the big conversation happening over the last 6 months, lots of opportunities to have community conversations locally, speak with people locally and so on. And so my experience in doing that, really going bottom up, getting out there, speaking to people, looking at the data, looking at the analysis and so on, pulling that together to say what are the sorts of things that we could and should be providing, much of which is going to hopefully come through in the 10-year plan, and being very clear about that and why we're doing that. I've done that across very large populations, and I hope that I will be able to replicate that here.
So Malaysia, so how did you do it? Is that the example you're using here?
Same sort, exactly the same principles as you would find here, but the good thing is we've got way better data here.
I'm just looking for specifics, please forgive me. I'm looking for so when you said you went to talk to people, what does that mean? What concrete steps were taken by you in order to make that happen? That's what I'm
let me give you examples from here then, because in some ways that's a bit
perfect.
simpler.
Yeah.
So examples from here would be all of those places I've spoken about, different bits in different parts of the country, and then doing national work, absolutely starting off with bringing together in a room members of the public, big public-facing events, everything from flip charts are all around the walls, so showing people what's actually happening in your area, here's some of the data in your area, here's what's happening in other parts of the country, what is it that you're looking for, what are the things that you would like to see, what matters to you, and so on. So big public-facing events, similar events with clinicians in particular, so putting out lots of data, this is how you're doing. Often people haven't seen that.
And this was in
data.
North West London specifically?
No, I've done this in many places.
Many places.
So lots of data. I mean, I've had difficult conversations. I've had really difficult conversations. Often doesn't go down too well. You are putting stuff on the walls about outcomes. You're saying, actually, you're not doing particularly well on this compared to other parts of the country, and so on and so forth. Lots on that. Again, bringing in these different examples. Often people haven't seen what they haven't seen, so this is how they're doing it 50 miles down the road, this is how they're doing it 5,000 miles away. But take a look at it, consider it, have a think about how it could apply here locally. Showing videos, so different forms of media to share some of those examples. Taking all of the outputs of all of those different things and then starting to develop different options. What are the sorts of things you'd like to do here? What could work? What couldn't work? Laying out those different options for different service models, whether it's down at an individual specialty level, like how might you organise cardiology here, through to how might you like to organise integrated care in the community here, taking those and then very tangibly turning those into partly options, but then options with analysis behind them. And saying, what are the evaluation criteria that matter to the local public, the local politicians, the local staff, and evaluating different options.
So can you give us one example of, and we're looking for a big change, so you said about stroke was taken, but it's quite specific. So a big change where you applied this model that you've clearly developed in several parts of the country. What's the best example that we could go look at of your work in delivery, not just analysis of the problem, which you're clearly very good at, but the delivery of the solution that then made things better for patients?
Well, first of all, it's not my work. I'm a conduit.
Okay.
I'm an enabler, I'm a supporter, and so on. And the work is always done by the frontline teams. And that would be true in this as well. I think that's a crucial bit about the role of the chair. So tangible examples I could point to. So some great stuff happening at the moment down in Dorset. I referred to that earlier. They are close to opening a new shiny emergency department in Bournemouth. They've built a very impressive elective centre at Poole Hospital, all on the back of some absolutely fantastic new models of primary care down there. They've got some, they already had some very good models, but they've built on those, spread them more widely and so on. So that would be a particular place I would refer to. Manchester, some good work there. They've still got a lot more to do, but some really interesting models of more integrated care. So North Manchester being a very good example, really brought together not just acute hospital care, but very vertically integrated with community care and so on. And there are plans in place around building a new
So
integrated
when was the work
hospital
in Manchester that you were referring to?
Well, the work was probably about 10 years ago, but in many of these examples, Dorset actually has been very quick. So they've moved very quickly. So actually, that's one of the quickest. So the work was initially set out in 2014, and they're literally building now. You know, many places, particularly changes in hospitals, can take quite a long time to bring through. I mean, you know, one of the first examples of one of these big pieces I did was in Hertfordshire, and actually I met yesterday with the chief exec and the incoming chair there, and they were talking me through many of the things that they've done, which built off some work from 20 years ago, and it's still work in progress, but they've made a lot of improvements there. One of the most tangible examples in hospitals actually was Trafford Hospital in Manchester, with Central Manchester Trust took over some of the responsibility for Trafford, which was really struggling as a site. Again, this is about 10 years ago, but they got really good data and analysis on that. And it took them a few years to do it. You know, it never happens that quickly, some of these things.
Yeah, we know.
But a real improvement in standardised mortality rate. So it went from something like 100, the norm would be 100, it went from 120, which is a high standardised mortality rate, not good. They got it down to, I think it was 92, something like that, very good. And significant improvement in operating costs as well.
Okay.
So
Thank you very much.
A few examples.
Appreciate it. Grace Stafford.
Thank you very much, and good morning, Dr. Dash. You've, in your submission, told us that one of your priorities for the first year as chair would be to, and I quote, clarify the relative roles of the NHS England, ICBs and providers. What changes do you want to make to these groups?
Well, at the moment it isn't up to me. There's a working group as part of the 10-year plan that is looking at exactly that question. I am part of that working group. There's actually another meeting on it this afternoon, and that work will be fed into the 10-year plan. And
yes, but just let me clarify. You said in your statement that's what you want to do. So from your point of view, what would that look like?
Well, I want to see clarity, because at the moment I don't think it's clear enough. So the bit I want to see is clarity. The 10-year plan process will come out with proposals. So I can input into those proposals, but I can't...
Okay, so what are you inputting into those proposals that you'd like to see?
Okay, so a few things specifically, just to point out, it's quite a long conversation. So, but one is, I think we need to be clear on ICBs. Now, at the moment, the view seems to be, from Secretary of State, we're sticking with ICBs, I'm supportive of that. But then we need to be very clear on what is then the function of ICBs. Are they strategic commissioners? Absolutely, but they don't necessarily have the skills and capabilities to do that at the moment. So there's a real need to build skills and capabilities in strategic commissioning. Happy to talk more about that, but that is a recognised need and it absolutely needs to happen. So that's quite a significant one. The second then is the relationship between ICBs and individual providers, whether it's GPs, wider primary care, or mental health trust or acute trust and so on. We need to be clear on what is the relationship there. So at the moment we do have a bit of a mix of a contractual relationship, including, as was referred to earlier by Andrea, about contracting with the private sector, but we also have a managed relationship. How do we make sure that we are optimising provision and so on across the geography? So I think getting clear on that, getting clear on where are we using contracts, where are we managing the system, that feels like a crucial bit we need to clarify, because at the moment it isn't entirely clear. And certainly one of the things I both see and I hear from people is they want that to be made clearer. So those are the sorts of things that I'm alluding to. There is another bit though, which I would say, and said I've been doing this wider review of quality, which will be published in a couple of weeks. But one of the big things in that is to be much clearer about the role of boards. So fundamental to getting high quality care, ensuring high quality care needs to be the role of boards. So that's whether it's a board of an ICB or it's a board of a provider. What are their responsibilities? What do we expect them to do? What does really good look like? And what are we going to hold them to account for? And in turn, their role then within their organisations. They are managing, again, very big organisations, quite complicated in a number of cases. How do they work with the individual directorates? How do they work with the individual teams? How do they work with the individual clinical staff? All of that needs work.
Yes, and I think you said in another part of your submission that you were going to look to significantly improve the governance and accountability, which is presumably the bit you've just touched on. So what currently do you think that isn't working about governance and accountability, and what tangible things would you like to see change so that it does work for you?
So I'd like to see a much greater focus on, well, I'd like to see a much greater focus on quality and productivity. You know, those are two of the key things. I think we could help from the centre about looking at what are some of the core metrics to look at in that. Again, we have the luxury as a country of having lots of data. We've got some really good schemes. I'll point to some things like the Getting It Right First Time, the GIRF scheme, which has some very good data in it, clinically led, really good on clinical outcomes. Are the boards looking at that data in their core board meeting? Do they know which bits of their hospital, in that case, are providing high quality care in line with some of the best in the country, which bits aren't, and therefore need a bit of a focus and attention? Same would be true in mental health care, same would be true in community care, and we don't have the equivalent of that board structure in primary care. So therefore that's where the ICBs come in. How are they looking at quality of care there? All of that supported by a stronger CQC, but I think that would be a real area that I'd like to see greater focus on, as well as some of the productivity metrics as well.
Thank you. You know how to push my buttons by talking about GIRF, so well done on that. Obviously, I should declare that I used to work for the Getting It Right First Time programme. How would you achieve that without significant change and top-down reorganisation? I know you've said that ICBs are likely to remain, but from what you've said, you seem to be advocating for quite a fundamental change in how things are going ahead. So how do you manage that from a top-down organisation? And from your role as the chair, what do you see your role in ensuring that the boards that you talk about actually produce the things you want? And if they don't, what sanctions do you feel you should have as chair to be able to impose or depose people?
Yeah. So I think in terms of, I don't think anyone wants to do a major restructuring. So I don't think that would win many brownie points really at the moment, and that seems to be the view of the Secretary of State as well. So I think it's about working with the system rather than throwing everything up in the air. So that's the first bit. In terms of then, I think it's a mixture of things, and I've referred to that a bit in here actually, I think under the question about working with NHS England, but the same things apply. It's a mixture of some role modelling. So I spoke a bit about board to boards. I think one of the reasons why I like board to boards is it's a good opportunity for role modelling. You can quite visibly, the questions that I might ask of another board, I would hope that then that gets them to think, okay, are we asking those questions ourselves? So I think there's a bit about that. I think there are some more formal mechanisms, so things like being very clear on what are the metrics that matter, what are the sorts of things that we would look at, but also supporting people to develop some of those things themselves locally to look at. To get to your final question, which I think is almost to cut to the chase, what are the sanctions? So it's a bit about, I think we do need a better balance of positive incentives as well as negative. There seems to be a bit of a tendency to jump to the negative sanctions rather than what are the positive things. So again, those are, I don't want to preempt it because there's a lot of conversations happening in the 10-year plan accountability working group on exactly the things that you're asking. But I don't think they would mind me saying those are the things that people are talking about and really trying to say what are the sorts of ideas and thoughts on both positive incentives for change as well as less positive ones. So I don't want to go into that in more detail because they're working on that.
I understand, thank you. You just said that you don't want a big top-down reorganisation, but both Amanda Pritchard, when she was here in front of us a few weeks ago, and she hinted at this very strongly, and it's been announced in the papers today that there is going to be quite a lot of restructuring between the NHS England and the Department of Health. So given it seems that the government's intention is to take increasing control over NHS England, how will you as chair ensure that the organisation maintains its operational and clinical independence?
Yeah. So first off is, certainly what Secretary of State's gone on record saying is he doesn't want to do a major restructuring in terms of changing legislation and so on and so forth. But to a degree, I know what you know from the papers and so on. Something I'm not in post yet. What I do think is needed, which I've a bit referred to earlier, is to be very clear on what are the functions that are needed from the centre. I'm really clear on that. So I do think this needs to be built bottom up. So we need to say to do all the sorts of things that we've been talking about so far to help local systems, not to tell local systems, but to help local systems. What are the things that could usefully be done once at the centre?
And when you say the centre, do you mean NHS England, do you mean the departments?
I think it's both. It's both. And, there are differential roles, clearly. There are things that the department does that NHS England doesn't do. There's lots that NHS England does that the department doesn't do, and so on. There are differential roles. There are also some areas that do work very closely together already. So I think it's about building that bottom up and then being very clear on, in order to support the NHS to deliver the sorts of things I've been talking about, what functions, what skills, what capabilities do you then need in NHS England? What are some of the things that are there in statute that need to be done, that you need to recognise that? What are the things then that the department needs to do, and how do you put all that together into a coherent, where groups of people can work effectively together?
So are you saying that under your chairmanship, the distinct line between the department and NHS England will blur, become more, let's be positive on this, more collaborative than it is currently? I mean, I'm trying to get a handle on what the Secretary of State seems to be doing and how comfortable or otherwise you are with that.
I'm very comfortable with the concept of what seems to be being set out at the moment of closer collaboration. That's the direction of travel. I don't have a problem with that. But it's hard for me to know more because I'm still outside.
Yes. And I mean, I suppose on that point of being outside, just, don't give me a precise figure, but on a sort of rough ballpark, how many conversations have you had with the Secretary of State in the last 6 months? Meetings, conversations, discussions, roughly?
Please check my diary.
Yeah.
About finger in the air, around 10. Finger in the air. But I check my diary.
Sure, thank you.
And in that, in terms of your application to this role, were you tapped up, spoken to by either the Secretary of State or anyone within the department to do this role, or did you just put this forward yourself?
Absolutely.
I mean, I suppose the concern that I have is that given the Secretary of State essentially sacked the outgoing chair for whatever reason, I want to be confident that you're not just going to be a mouthpiece for the Secretary of State and the department. So what reassurance can you give me on that?
I'm a strong person. I have lots of thoughts, I have lots of ideas, I've written a lot, I'm very well networked in the system. I go back to data. I mean, the reality is you're working within wherever the current ministerial and political team is. So I need to work with the system, but
and
I wouldn't describe myself as a mouthpiece for someone else.
Well, that's what I would hope not. But that's what I wanted to hear you say it. just my final question then on this, sort of going back to where I started. In your application, you said you wanted to clarify and simplify the relationship between NHSE and the department, and you also said that the interface between NHSE and the department should be better utilised. You've described to a degree what you meant by that. I suppose what I want to understand is, do you say that because you know that's where the Secretary of State is going, or is it because you fundamentally believe in that change of relationship?
I think I said the first, not the second.
Okay.
But in the first, I say it partly because I have been doing this work in the last, whatever it is, 8-10 months, on, first of all, reviewing the CQC, and then secondly, looking at the wider policy landscape. And I've been working very closely with DHSC on that. They provided me with a small team. They helped me with quite a lot of the data and setting up meetings and so on. And I've also been working with NHS England, who've also got data and so on quality of care. And at that tiny little level, there is some duplication.
Thank you very much.
Thank you. Josh Fenton-Glynn.
Thank you, Dr. Dash. So one of the big parts of your job is going to be kind of enabling the delivery of the 3 key shifts.
Yeah.
I looked at something that you said in an interview with the Institute for Government. It's a slightly abridged quote, but you said we could roll out neighbourhood care within probably a few weeks in northwest London, but we've got to be willing to do it, and we've got to tackle some vested interests.
Yeah.
What vested interests do you need to tackle?
Lots.
Okay.
So we have, we've got to the place where we are over many years. Already referred to before that we do at the moment put a relatively high amount of money into our hospitals. The hospitals aren't standing up at the moment and throwing money back at the ICB and saying, please spend more on primary care, even though they themselves would absolutely say that they would like to see a better functioning model of neighbourhood care. Yeah. But that requires changes to be made, and that's going to take time to do, and that's going to take a lot of working through with local teams to do. So that's one.
Forgive me, you're being a bit, you're talking around the subject, but what you're essentially saying is we need to pull money out of hospitals and put it into the community.
Well, if we want to change the relative balance, either we make differential investment decisions as the amount of money in the system goes up, but in a world where we're not anticipating vast increases in the amount of money going into the system, then that would mean starting to transfer funds. But exactly as I said earlier, that is obviously not easy to do, and it's not straightforward to do, and that will take time to do. So that's one bit. And then the second bit is in terms of bringing together those integrated neighbourhood teams, there are multiple players. The term, it is integrated teams, so it's teams from social care, from community care, from wider voluntary sector, and so on and so forth. And all of those people, quite rightly at the moment, are quite focused on their own organisations, and so bringing them together will take time to do. So the bit I was saying is on paper, you can set that out, but to do it in reality will take time to do, and have to work with all of those people.
So, talked a bit about hospitals, and you've talked about kind of trying to bring people together.
Yeah.
Do you think there are other vested interests that you have to overcome to deliver the 3 shifts?
I mean, in some ways, if I talk about people working outside and hospitals and people in hospitals, that covers the workforce. There are obviously politicians, both local politicians and national politicians, who rightly take a very active and interested view in what's happening locally. There are some of the big unions, BMA and so on and so forth. All of these organisations all have an interest in what is happening. So it is a complicated landscape.
Yeah. And what kind of challenge do you expect from the BMA?
I don't know any more than I've already, I mean, you can read the stuff, I read the stuff, and you read the stuff. I've had no conversations other than bits that you would have seen in the press. So, I mean, my sense is that there's, if you look at what the GP community is saying, the GP community is crying out for change. So.
Yeah. So, I mean, so obviously parts of it will cry out for change, but yeah, I'm kind of curious as to what you think the difficult conversations are going to be.
I generally don't know, because I haven't had those conversations, and it hasn't yet been laid out in the 10-year plan and so on. I mean, it's still quite high level. I support the 3 shifts, I think most people do, but it's quite high level, and I think it's a lot about getting into the detail of that. So it's hard to know until you see the detail, I think, to be honest. But
okay. So in your role as chair, which is obviously different than the chief executive role.
Yes.
So your job is to enable the chief executive to make those 3 shifts. In terms of your leadership position and kind of setting the vision and enabling them to do it, what do you foresee as the big challenges?
For the chief exec?
No, for you as chair, what will you have to do to enable the chief exec?
Okay, yeah. Well, I think I put in here support and challenge. Those are the kind of terms I would use. So I absolutely see that the role of the chair is both of those. So it's to support their chief exec, to absolutely be there as another pair of hands to a degree, able to help in whatever way, and a lot of that depends on the personality of the chief exec. So we can work in different ways depending on a bit about bringing both sets of skills and strengths and so on to it. A lot about being a good sounding board, someone to speak to, someone to bounce things off, so on and so forth. So there's lots of things in that supporting role. In the challenging role, it's about saying, are we doing the right things? Are we being ambitious enough? Are we challenging other bits of the system enough? Are we putting the investment in the right areas? Have we got, to be honest, many of the questions you're asking, have we got the right sorts of people in the right places, working the right way to deliver on this agenda, and so on and so forth. So I think the trick is getting that balance right. If you go too much on the support or too much on the challenge is where you start to get a bit of a difficult relationship.
Okay. I feel a bit like in your answers to your questions, you either go very operational, so you talk about things that you've seen on an ICB level, or you pull back and you're quite general and then say, well, the 10-year plan isn't in yet. I'm almost looking, when I'm trying to look at the chair for this organisation, the person that's going to deliver that chair, for something in the middle, that kind of, what am I practically going to do in order to open up the NHS for the 3 shifts? If you want me to take one message away when thinking about what you're going to be like, but the kind of personality of Penny Dasher's chair, what would that be? What would be the thing that you would bring to it that would make it different?
Right. Well, that was called, the Guardian called me a reforming zealot and a no-nonsense character. I thought, where have they got those from? That's probably a reasonable description. I'm ambitious. I am ambitious. I'm ambitious for change. I've spent a lot of my life working on these topics. I care deeply about these topics. I care deeply about equity. I care deeply about quality of care. I think it's unacceptable that some people get some sort of care and other people don't. I do care deeply about making good use of resources. I think that's a fundamental obligation. I do think we have a fantastic opportunity at the moment to make some real tangible changes and shifts, and I will absolutely be holding not just the chief exec and the whole exec team to account on that. Are you going far enough, fast enough? And we can get into a lot more of the detail of that. I'm not sure we've got the time for it today, but also I do want to respect the 10-year plan work and all the people who are involved in that. So I think we need to give that its time to come out, and then sort of take that, and then I'd like to then get into, as you say, that
and
level.
Then run with it as the reforming zealot that you are.
Yes.
Fantastic.
Absolutely.
Okay, thank you very much.
Joe Robertson.
Thank you. Good morning. You've talked about ensuring there's an effective executive team in place, and of course you'll get to appoint a new chief executive, as Amanda Pritchard is standing down. What are the qualities you're looking for in a new chief executive to help deliver all this reform and change?
Well, I believe, but again I haven't been fully party to it, I believe that Jim Mackey is going to do this for the next 1 to 2 years, I believe. Mm-hmm. Mm-hmm. So I don't think it's an instant decision. I think he's agreed to come in as an interim to do that. But I know Jim. He's obviously done some very positive things in the past. I should also say I've got a lot of respect for Amanda, and she's been leading the system through some very difficult times over the last few years, and I thank her for that. What do we need to do now? We absolutely, I think, have got to do the sorts of things I set out. I'm applying to only be the chair, not the chief exec. So I need to, first of all, have conversations with the chief exec to build that alignment. We won't be in completely unified harmony. It would be a bad thing if we were. So we will have some differences and so on. We'll have some different ideas. But what I would be looking for is someone who shares the passion and commitment for change. Because otherwise that'd be quite hard to do. I would look for someone who has some of the insights, has the experience and the expertise and the knowledge and so on. I'd be looking for someone who's very comfortable with data and analysis, particularly around these big topics of quality, productivity and so on. And I'd be looking for someone who's got a good sense of what's happening in the wider world. Obviously some of the things around tech are big, they're potentially massive opportunities, so that ability to look out as well as to look in is crucial. And then final bit, by no means the last, is someone who can work very effectively with people.
So thinking about the executive team rather than the chief exec per se, I want to invite you to reflect on where we maybe haven't achieved or delivered as we'd have wanted to in the last few years, and perhaps invite you to identify some of those areas, and therefore that's what you would want to see the new, refreshed team deliver on. I think it would give public confidence if you could reflect on some of the perhaps weaknesses, for want of a better word, in recent times.
Yeah, I'm not sure they're weaknesses, and in some ways they're more sort of outcome of circumstance to a degree. But what are the things I'd like to see? If I look forward, I think tech. I mean, we are in a very, very interesting time, and some of the things that are bubbling through are amazing. Absolutely amazing. You know, as many people have said, though, we've also got to get the basics right. So we've still got staff that can't even switch on their computer. I mean, it's just ridiculous. You know, people are saying that they come into work and it takes them half an hour to log on, and they've got 5 different log-ons and so on. I mean, you know, it's crazy. So I'd like to see the basics absolutely resolved, as well as then some of the stuff that's coming through now. And it is fascinating, some of the things coming in. The ambient voice technology seems to be having very positive impact very quickly. And that's, again, both on quality and on productivity. So I've seen a couple of sort of mock-ups and people demonstrating some of that, and it's phenomenal. It's absolutely amazing. Some of the other things that are coming through on the tech side, as well as some of the data and analytics, so doing things like using predictive modelling tools to do better scheduling of operating theatres. You could do that for outpatient work, the potential to take a big chunk of outpatients and use digital tools to redesign the processes, have it work better for patients and for staff. I read the King's Fund report they did with Healthwatch and National Voices a couple of weeks ago on 2/3 of people in the country had experienced administrative errors. Certainly that would be in line with my own personal experience, getting wrong letters to the wrong address at the wrong time and so on. So all of those things, that would be a really big thing. You know, I think we've absolutely... Now, the issue is comes back to differential investment. You've obviously got to invest in those things. You've got to invest to save. But I would like to see far bigger investment in the technology to do those things. And then the bit which just referred to earlier that I thought you were going to say that I've been speaking about at that event was around operational management. I think we've got lots of people working on improving operations in terms of the operational functioning of the system, but there's still a way to go on that. So that's where I would go big, those two areas.
Okay, just thinking about that good example actually of technology, but getting the basics right before, you know, walking before, you know, not running before you walk. To what extent, not managing to get the basics right so far, is it the responsibilities, the accountability rests with the executive team, or is there some accountability lower down in the system that should be held accountable for that and is indeed responsible for that? So, you know, 5 logins doesn't necessarily look like an executive team accountability issue. It's somewhere lower down. So how are you going to ensure that accountability is felt?
Yes, I'm asking myself that. Isn't it? I don't know. That's why I keep asking myself.
Well, I think if you can achieve that, you'll achieve a huge amount, if I may say.
Exactly. Because you think, you can't... doesn't need to run that from... You know, NHS England, that must be a local thing, isn't it? I don't know. I honestly don't know, but I'm asking myself the same question.
Yeah, I mean, from my point, it's not about my opinions, but I think that's probably a major issue within the NHS.
Absolutely.
It's such a big organisation. How do you ensure the accountability at lower levels, not just at the top?
Absolutely,
Before I pass to my colleague, can I also just ask about your the board itself? Because we talked about the executive team, but of course, as chair of the board, you'll be responsible for that. Do you envisage making many changes to the board in terms of structure or specialties?
So there are 2 non-exec vacancies coming up. So there's a process at the moment. The applications closed, I think, last week, and I will, if I'm appointed from this, join the interviews, which will be at the end of March.
Is there a glaring gap that you're hoping is going to get filled that you can see?
I've looked at the current and then some of the people coming through. One gap which has been flagged and a number of people have said is definitely around primary care, neighbourhood care and so on. So that's definitely one. I think that strikes me as that's a gap at the moment in terms of the non-exec team. So we'll see where we get to with this round of interviews and so on. There's a lot on, I think, mental health, particularly children, young people's mental health. That's obviously a big topic. There is Simon Wellesley already, so we'll see where that is. And then I think it's come back to, you know, the whole point on technology and so on. That's obviously a really big area. There are people on the board with expertise in that. The other one, which we haven't spoken about much, and I did realise I didn't actually write about much, which was a bit of an error, was some of the sort of out there stuff, so in life sciences, genomics and so on, and there's some really amazing things happening again. So how are we really working with partnerships on that to make sure that we remain at the leading edge globally, I think, in terms of some of those things. I mean, they're challenging in terms of their enormity, but potentially really quite exciting and interesting things.
As an Oxford MP, that gets me excited too, I will admit.
Well, I think, for example, in you're in Oxford, aren't you? The Ellison Institute, for example, I'm going to see that in a few weeks, but, that really interesting. How do we make sure we maintain enough contacts and connections and things like that?
And you set the culture for the board. How interventionist do you feel it's appropriate for a board to be? What's your style? Because every chair is different.
Every chair is different. So I get asked that question a lot, and I do think about it a lot. And I have also spent a bit of time speaking to lots of other chairs, so I'm quite interested in that, and reading as well. There's quite a lot written about different types of chairs and so on. And I learnt a lot from that, actually, going and speaking to people. I really learnt a lot. It's made me think quite a bit. I do think
these are recent conversations you had preparing for this, or
no, more over the last 5 years. So I was. And I think one big thing that comes up, it is circumstantial. If you are chairing a sort of, for example, something like some of the digital startups or early SMEs and so on, that's a different dynamic than something like Northwest London and the NHS side. So it's definitely circumstantial. Different sorts of organisations, I think, require different roles. I think it's definitely a bit about that we were talking about before, the different dynamics between a chief exec and a chair, and trying to get the best of both. So moderating the style depending on the sort of person it is. I probably can't get away from the fact that I am trying. As you will have picked up, I'm obviously interested in lots of things. I look at lots of things. I like running quite a lot of the numbers myself and so on and so forth, and not all chairs do that. So I would say I am probably, which my current chief exec would raise his eyebrows at this point, probably a little bit more of a interventionalist.
You run the risk of stepping on a few toes.
But I definitely run the risk. So one of the big things is that stepping back. And actually, I'd say I have been trying, and I'd like to believe I've got better at doing that, actually. I've got better at saying, these are the things I will get more involved in, and these are the things I absolutely won't. I'll assure myself, but I won't get deep in, sort of dig into the real detail on that. I'll leave that for the executive team to do. Yeah.
Thank you very much. Dr. Vicky Cooper.
Thank you, Chair. Thank you, Dr. Dash. And as you have just said, you have got an interest in lots of different parts of healthcare systems. And I just wanted to focus your attention on your chair role in North West London and your interaction with NHS England. And if you could just reflect for us a little bit about how you see the culture of NHS England from that role, that would be really helpful.
Yeah. I mean, we've had very positive relationships, but I'm aware through conversations with some others that the dynamics are different in different places. So that's something I'm quite interested in.
So, Dr. Dash, when you say positive, what is it that you're sort of experiencing from NHS England that leads you to believe that is a positive culture for you?
So NHS England, both the regions and national. So in terms of the region, we have a good level of interaction. So I get support. That's a crucial thing. Always both in the regional directors I've worked with, a lot of support. I can pick up the phone and say, well, we're stuck with this, or could you help with that, or what do you think about this, and so on. So we've had a lot of support, and that's been really helpful. We've had some good conversations about what are things that we think we could do jointly together, and how do we get that balance right between what we do at the ICB level versus what we do at the regional level. Those have been good conversations. Wouldn't say necessarily always agreed on them, but they've been good balanced conversations.
Okay, so sorry, I'm going to just because I'm going to try and move on. So that sounds all positive, and that's great. So if I look back to what you said earlier on to one of my colleagues. One of the things that you are interested in is around decentralisation and having less of a focus at the centre. Yeah. So I understand it's great you've had a positive relationship with NHS England, but as the incoming chair, you will be, if you're successful in this appointment, you will sort of help to set the culture of NHS England.
Absolutely.
Do you foresee the devolution, possible decentralisation of NHS England as a positive move for that culture, or are there issues that you can foresee coming forward?
Yeah, okay. So largely positive, because there are a whole set of things that do come from NHS England. So I've given you the positive, but some of the things which more come from national rather than the regional, I don't think should be coming. And, others have spoken about that. Patricia Hewitt went into quite a lot of detail about that in her review that she did. But
so you generally agree with the Hewitt review as to what came out of it?
Okay. Yeah. So I definitely think there's more latitude for people to decide locally. I mean, there is quite a lot of telling that I'm not sure is necessarily the most constructive. So that I'm definitely supportive of that. At the same time, which I alluded to earlier, I do think that there are things which could be better done once. So I think of, for example, the old principles of healthcare value. How do we really understand what's the potential impact, what's the return on investment of different healthcare interventions, where should we be putting our money, what could an optimal cost structure look like, and so on and so forth. It does not make sense to do that 42 times, and we definitely do not have the skills and capabilities to do that 42 times. So I think there's quite a lot of things that could be done. I mean, I think in the whole public health field, there's quite a lot of things which actually as a country we've done really well by doing nationally and so on. So I think getting that, the evidence base, the understanding, the analysis, doing that once. But then how do you deliver that? How do you develop the priorities? How do you decide what you're going to do in these particular streets or in this particular neighbourhood and so on? You can't do that nationally. That absolutely needs to be done locally. So
it sounds to me as though you're saying that currently you don't think the balance is that there's too much centralisation currently, and that you would be supportive of seeing a more decentralised NHS and therefore a more streamlined approach to NHS England as a sort of central function.
So many people, not necessarily me, there are many people who are saying they would, including NHS England, saying they would like to see more things decided locally. I have actually, I've had a go at starting to lay out some of the things. It's quite interesting when you get into the detail.
And that's fine. If you're successful in this appointment, then you will be the chair, and you will be, part of your role will be to drive forward sort of the cultural change, and you would be supportive of that.
Yeah, I think we absolutely need to say these are the things that could and should be done locally. And these are the things that could and should be done nationally, and I think we should have a sensible conversation and debate about that, based on the principles of subsidiarity.
Okay, yeah. And one final one from me, just sort of listening to you, and as going back to, obviously you've done a lot of things, you've got a lot of interests, and as the chair sort of rightly pointed out, there are different types of chair in terms of interventionist. How comfortable do you feel about moving from that sort of more operational sort of approach? I know you're an ICB chair, but I've seen what you've done. You have sort of been pretty hands-on, moving to a more strategic role where you are sort of looking at that bigger picture. So I guess my final question would be, if you are successful in this appointment, in 10 years' time, what would you say that your input would have been that I would be able to say, okay, Dr. Dash was the chair of NHS England, and in 10 years' time that strategic vision has come through. How would you want me to be able to see that?
Okay, I think you're asking two different questions.
I am asking two questions, yes. You're right, yeah.
So I think in terms of the strategic vision, if we could deliver those 3 shifts, hallelujah.
Okay.
So, that's, I think, reasonable. But we've got to then be clear on what does that actually mean. So I do think that over 10 years, it's not just about going 3 shifts, we've done it. That then has to translate through into better health outcomes, better life expectancy, better quality of life, better access, and so on and so forth. So there's quite a lot in that.
And sorry, just to be clear, so your contribution towards that 10-year vision
is then your second question, which is what would my role be as the chair as part of that. So first off, again, I work within the framework that is set to me by the government of the day, so to be clear on that. And then I absolutely think it comes back to me working hand in glove with the chief exec, with the exec team, with the whole of the workforce, and we haven't actually spoken that much about the 1.5 million people, with the whole of the workforce to actually deliver these changes. And I absolutely recognise, I think that the specific role of the chair, which is, again, I'll come back to, so there's a support function, there's a challenge function, there's bringing clarity there's being a good communicator, there's being a conduit, so listening to people, picking up what different people are saying, and so on and so forth. It is absolutely not being operational. So
Okay.
I think it's more, how do you get that balance right?
Okay, thank you.
Thank you very much. Ben Coleman.
Yes, thank you, Chair. And I should just begin by declaring that Dr. Dash and I know each other. I had the pleasure of serving on the Integrated Care Board for North West London while she was Chair, for a period before I was elected, until I was elected, and she's still the Chair. And maybe I'm one of the vested interests you referred to, Penny. Would that be the case?
No, no vested
Be
interest.
honest. In fact, we'd encourage you to be.
Vested interests aren't necessarily individuals, they're groups.
Okay. Well, I'd like to come back to the relationship with NHS and local authorities, and perhaps that would be a better way of entering that. But I'd just pick up on you noted that I tried to probe a little bit with Julian Kelly about hospitals, because I think it's prevention really is what I'd like to start by talking about. Because prevention, obviously, we see largely, it has been seen largely in terms of the resources given to for public health, which is hugely important, of course. But there is a role for lots of other bodies in the NHS to support prevention, and it's not very well defined at the moment. No. So I was trying to probe with Julian Kelly a little bit about the role of hospital trusts in that. My feeling that he, coming back to me, was saying, well, hospitals don't have any incentive to support social care, particularly because as soon as you get somebody out of hospital, you've got another person waiting in a long waiting list for an operation. So what is the role, do you see, of hospital trusts in prevention, and how could we incentivise this?
Okay. There's actually quite a few things in that question. So I'll take, first of all, prevention in terms of primary prevention, and then I'll come on to secondary prevention, because I do think, even though they overlap at times, there's a crucial difference. So in terms of primary prevention, so that would be various things like smoking, obesity, breastfeeding, so on and so forth, as well as, of course, the wider determinants of health, which we've obviously done lots on, and so on and so forth. But in terms of that primary prevention, so I don't think it's the role of a hospital, per se, to be running a big smoking cessation campaign or to be doing work with local authorities looking at ways of getting easier access to healthy food and so on and so forth. I think there's plenty of, hospitals can do what the hospitals do. What I do think the hospitals could do is some of the prompts around that, and to come back a bit to the technology, there's some really good examples in other parts of the world whereby, particularly if you've got a really good electronic health record or great data systems and so on, you turn up in an A&E, if you haven't had your HPV vaccine, or if you haven't, your blood pressure hasn't, obviously they check your blood pressure, that's an example, but if you haven't had, your flu vaccine or whatever, it comes up in flashing light on that electronic health record, and literally they would there and then, if someone, even if you're there in A&E with a broken arm, will get that flu vaccine in you if you're due one. I think we could do a much better job on that. We're one system, we've got a single patient data records and so on. We ought to be able to do that, I think, in a much more impactful way. So that would be an example around hospital role in primary prevention. So in terms, though, of social care, a bit more you're coming to, or more the secondary prevention, so again, particularly for people with greater needs and so on, I think that's more about everyone working together as a system. And in some ways that comes back to some of the questions Gregor was asking about the sort of role of ICBs versus providers and so on. We don't want to make it too separate. It needs to be because you want everybody to work together to be able to say where are there opportunities for us to fundamentally redesign this system, because it is in no one's interest to keep admitting people to hospital who don't need to be there. Yeah, no, I and absolutely. So on and so forth. So how do we all work together to understand?
So how do you? I mean, hospitals at the moment, I think, do by and large a brilliant job, but no one's perfect in the system. Yeah. Hospitals don't have a direct incentive, as it were, although to keep people out of hospital or to keep people supported by social care at home so they can live independently, and any hospital entry is delayed by maybe a decade. Yeah. How can we incentivise hospitals differently?
Or how can we incentivise the system? Yeah. Because it might not necessarily be that you want to incentivise the hospitals for that, you might want to incentivise someone else for that. Okay. So I do think I was worked with NHS Confederation about a year ago to write a report on payment reform. and we looked at some of the different models that exist, again, in other parts of the world, particularly on the risk-based models for out-of-hospital care, for bringing together teams, including social care, including primary community mental health care, and so on, and taking on more of the risk for managing that community and that population. So looking at those incentives, I think, is a really interesting one, and what's the best way of funding that, and so on. And that's a really crucial topic. And again, I'm pointing a lot to the 10-year plan, but I'm hoping that the 10-year plan will do some good work on that. Yes, we'll come out with something good on that. So I think that's one. In terms of what do we want to incentivise hospitals for, I think we want to incentivise them for doing all the great things that we need our hospitals to do, like really high quality care, like good throughput, good productivity, and so on. And so we need to think about how do we get these incentives right and those incentives right, and even where everyone's doing everything. So people talk about things like moving to more lead provider models and so on and so forth. So it's a very, very complicated world, but I think there's some really good examples from other places, and indeed things that people have looked at here that could be done.
Oh, that's interesting. So I guess I was coming from a different place in terms of the potential for hospitals to do more in the community, from where I had the impression you're sitting. But as we move towards the plan towards more community, the focus being on the community and primary care, obviously that needs funding. But there's a lot of discussion about double running. Yeah. How are we going to fund this? Are we going to take money from hospitals now, which are already in quite many of them are having need repairs which are being delayed by decades? Are we going to take money from hospitals, or are we going to do double running, where we continue to fund hospitals properly as they are funded now, and also find the money that was needed to start the improvements in primary and community care?
Yeah.
So what's your view? Should we double run or not?
Well, in an ideal world, you would. You need to build up different bits and so on, but I think I'll keep coming back to, I don't see that magic money tree at the moment. So you may also, I can't see where there's suddenly going to be a big influx of money to come in and do that. So we need to be pragmatic. What I do see, and alluded to it before, is I see some amazing opportunities that are bubbling up to deliver the same care at lower cost. And that's where I think we should go. The
same care in a hospital or in primary situation?
Particularly in a hospital, but some of that would apply in other settings as well.
So you'd make hospitals more efficient, save some money there, take that money and spend it in primary community?
Yes.
And if the hospitals didn't become more efficient, would you shift money from hospitals, cut hospitals' funding in favour of primary and community anyway?
Well, there is and this is, I asked this question, I'm obviously wrestling with this myself somewhat. So we need to look at the entirety. We need to look at where there are opportunities to do things differently. We need to say, what could we put in place to enable every single bit of the system to do things differently and better? I think your point then, what if it doesn't work? And what if we can't do that? And so on and so forth. We need to then, because we know some places are already doing things, we know there's a big variation. So if we get to the place where even with the most intervention in the world and all the rest of it, that place still isn't doing something, then...
So the place being what the...
Well, it could be anything. It could be a community trust, a mental health trust, an acute trust, and so on and so forth. But we can see that, or it could be a department within it. We can see that already at the moment, that we do have big variation in terms of essentially unit cost of delivering the same activity.
I mean, I guess what I'm coming to, I'm pressing you on, forgive me, because it's a particularly live issue, and
yes.
Sort of declaring my interest in North West London, where Andrew Lansley brought out a document which I know you're well familiar with, Shaping a Healthy Future, which would have closed the A&E and Ealing Hospital and Charing Cross Hospital, and effectively got rid of most of the site in order to fund improvements to primary and community care. That didn't happen because of the campaigns which I was involved in, as you're fully aware. Is that, however, the only way we're going to get funding now for community and primary care, by taking it away from hospitals, or would you hope that you can find other sources of funding? But if not, is that the route we have to go down again?
Well, A, there's a lot more money in the system than there was back then. Secondly, there's a lot more technology and a lot more focus on the opportunities of technology. So what I would like to see, back to, is some really good modelling which actually sets this out. I don't think this should be a hypothetical question. I think we have enough data and analytical capabilities that we could make it a real... At the moment this is hypothetical. I want to see the data that allows us to see what do we think we could do, and that then allows you to see what are some of the choices.
So the double, I talked about double running because in meetings with members of Parliament, the ministers in the Department of Health at very senior level have said that they believe in double running. But are they perhaps being a little bit optimistic given the situation in which we find ourselves?
I don't know, because I haven't seen the data and the analysis.
Right, so they might be being optimistic, but you don't know.
I don't know.
And that's because you don't know the money in the system.
Well, we know the money in the system.
Yeah.
That is a known. We know the population and we know the money in the system. But we also know an awful lot about what are good interventions. We've got a lot of data, a lot of research and a lot of best practice examples. And what I am looking to see is we take the population times the interventions and the best practice models times either an optimised unit cost or a realistic unit cost, because you never fully get to a fully optimised. And then we need to say, what does that then mean? If we could do that analysis, and that I think is what is referred to in the zero-based reviews that are meant to be happening or are happening and so on, if we could do that analysis, I think that would give us the data that we need, that these then cease to become hypothetical conversations and they become real conversations that allow us to see.
And zero-based budgeting is, of course, a good way to go in any system, but obviously the NHS is a system unlike any other. The size and the complexity and it makes it more difficult. So, but having done that sort of analysis, I get the feeling you said there is more money than there was when it was at the time when the previous government felt it was necessary to close 2 hospitals to fund primary and community care, and you say there's more money in the system. So you think there is another way of the idea of double running where you would fund community and primary care to get up stronger. If they took the pressure off hospitals and fewer people went into hospitals, then of course you wouldn't have the same need as you have today. But until that happens, they would continue both to be funded. You find other funding for primary and community.
I honestly don't know.
So it might lead to cuts in hospital funding.
I don't know because I haven't seen that analysis.
Okay, so that's helpful. Thank you. Coming to the local authorities, the person spec for the job talked about having an understanding of the contribution local authorities make to delivering positive health outcomes, and the Secretary of State, when he came to us, said he didn't think that local government feels like an equitable partner. This is, I think, quote is, feels like an equitable partner around the table with the NHS. So how well do you think the NHS understands and works with local authorities and vice versa, and what can we do to strengthen that relationship?
So I'm a bit more positive, but you may tell me otherwise, but I'm a bit more positive because I think we've had some good conversations and done some good work in North West London together. Is there room to improve? Absolutely, there's room to improve. And again, I said earlier, I hear a lot about some very positive examples around the country, and I'm interested to go and see those and see, what the view is of those, because I'm absolutely sure it will not be the same across 153 local authorities. It will be very, very different.
It will be different. I mean, my contention, which we have discussed in the past, is that the NHS broadly doesn't understand social care, and social care doesn't understand the NHS as well as it could, but it understands it better. And we took a visit to the Isle of Wight, which was very interesting because there was a real gap in the relationship between the ICB and how they approached the social care team, and not to mention the third sector team. There was a real space there in terms of understanding and ability to work together. From your experience, how can the NHS be helped to understand social care and to get better, more out of it?
And vice versa.
And vice versa, as I said at the beginning, and vice versa.
I think through relationships and dialogue. It strikes me that's usually the best way to go. And what I hear from the places that do feel that they have a better relationship is because they've got that. And so that's the bit I think I'm well, I've already said it, very keen to go and learn more about and see more about that and see where are there. You know, people do speak very, very, very passionately about some of the examples where people have made a lot of progress on these areas. So I want to almost go and see it and understand the different elements of that.
Yeah. Do you think it's the idea of a national care service, which is much discussed? Is that something that should be left to local authorities, or should be run out of the out of the Department of Health and Social Care?
I think Louise Casey is going to tell us.
What do you think?
And you're doing your own inquiry as well. I did listen.
Just help inform.
I listened into some of that, so I will leave it to the people who have been asked to give a view on that.
So you think there might be some argument for taking it from local authorities, or?
I will leave it to the people who've been asked to give a view on that. It's not.
Okay, that's fair enough. So you talked about our growth. I was just going to move on to something else, which is very interesting.
Before we do, I think
yeah.
we want to help.
Oh, I'm sorry. Please, yes.
It's
of
just,
course.
Then we'll come back.
Do you mind, Ben? It's just, I was really interested with what you said, so I wanted to bring, from what Ben was saying, back to your role at NHSE. With all the changes that are going on at NHSE and you going in as the chair, do you feel that NHSE is agile enough? And what would be the two things that you would do as the new chair to encourage the new chief exec to make it a more agile organisation and not so cumbersome? Sorry, that just was a
great question.
That's all right. So I think there's two bits of saying how do you get an agile organisation. Even three bits. So the first bit is to have the right functions. So I talked about that bit earlier. So I do think that there is a need to say, in the light of where we get to in the 10-year plan, what are the functions that we need in NHS England? And I think we've got to be clear about that. So we need to build it bottom up, whereas at the moment it tends to be a bit top down. So what are the functions that we actually need? What are the skills and capabilities and so on that we need to do that? So that's the first bit, get those, you know, the right people working the right roles in the right place and so on to do it. The second, which quite a lot of people talk about, is culture. And I tend to say culture doesn't happen by accident. Culture is a deliberate outcome of lots of things. So that is about putting in place very clear, I think, role descriptions for people. What do you expect from people in their work? Being clear on the values that you recognise, the purpose, and so on and so forth, about good support for people, development of people, ways of working, performance appraisals, incentives, and so on and so forth. So there's a whole set of things around culture, as well as crucially role modelling. And I will come back to role modelling. I think there's a big thing about the way in which particularly the leadership of any organisation works that then does dictate and ripples through organisations and so on and so forth. So there's an awful lot in that culture bit. And then in the agile, which is the term you use, interesting term, there's a lot of people who've written quite a lot on what is an agile organisation and how do you get to that. And there's quite a lot about things like sprints, all these buzzy management words, but you know, people doing fast sprints and working in different teams and working in different ways around the organisation and so on. And I'd be interested to explore that. I don't know whether any work's been done on that, but I think
but I'm not asking about work that's been done.
Yeah.
My specific question is, you are going in as the chair. I've read all about you. I've read you are on paper a very dynamic person. I'd like to see a more agile NHSE.
Yeah.
What are the two things that you'd like to see to make that organisation more agile? Come on, Penny, show us who you are.
Well, it's probably not just NHS England, it's actually across the whole system. We'll start there, because that's only my remit. Well, I share your enthusiasm. I think it is a bit about, you know, start from the top. It is about bringing some. People talk a lot about hope at the moment, and I hope I can bring some hope. But I think being clear on what it is we're trying to do, sharing some of these examples to say it is possible. You know, there are really great examples out there. Being very clear on what is everyone's individual role and how do we recognise and support every individual. You know, I think it's those sorts of things. That's what I read and that's what I see and that's what I've been part of in in other places.
Thank you. Chair, back to you.
Thank you. Yes, just a couple more things, but you'll be glad that bouncing along. And the growth, and we're talking about getting enthusiastic.
Yes.
So it's always a very exciting subject to talk about growth, and because this country desperately needs it,
Yes.
and it is also exciting thing about the opportunity that the NHS can play in stimulating and encouraging growth. And you touched on life sciences, and in my part of London, I know that hospitals are working very closely on trying to develop life sciences. How do you see the role of the NHS, and NHS England's particular specific role, I should say, in supporting and developing growth?
Yeah. So either we can go a bit parochial and talk about White City, but I think if people haven't been to White City, I would definitely go and look, because it's absolutely fascinating, isn't it? You know, really interesting example of A, urban development, but B, go to this White City area, which is in White City, it's in West London. There are everything from some really big companies there to a whole host of startups. And it's real, I mean, it's very dynamic. It reminds you of sort of startup culture in other parts of the world and so on. And of all those companies that are there, 70% of them have some involvement in healthcare, either directly or indirectly.
Yeah.
And at the same time, got world-leading university there, world-leading medical school there, all sorts of research and so on and so forth. And a population that ranges from, you know, literally classic London within, 30 yards from the plush flats from where the BBC was, through to the council estate with a high proportion of people who came as refugees from Somalia there. So all of that in one geography. And how do you use this inward investment, which is essentially what it is, in very dynamic, high growth industries, many of which are in healthcare, to both stimulate local employment and local economic growth, and also benefit the local healthcare services. So that is the real...
That's a great question. And so how does NHS England take a role in that?
So A, I think by calling it out. B, by doing things that you can do nationally, because that is a very local example, but I think it's the things that you can do nationally that really endorse that and support that. I think whoever came up with the fourth objective for ICSs, which is that, economic and social development, that was great, and I will try and take that with me, because interestingly that isn't in the objectives of NHS England, although it's in the objectives of ICBs and ICSs, so that's quite an interesting one. So let's take that, because I think that's a great one, but also then make it really practical. So some of the practical examples are, and so I'm going to Manchester this evening after this, and actually this is going to be a big topic in Manchester, and they're very proud of what they're starting to do in Manchester on some of these same things and so on. A lot of economic development around the health agenda. The Health Innovation Network up there is very much at the forefront of that, trying to drive a lot of that, working very much with local government, universities and so on. So I think we've got these examples around the country. How do we take these different examples and say, what are the things that we could do really well of it? And if I just take one I really like is, so there's one startup which has come out of Imperial, which is you put a little mouse on your chest and it does an automated reading of the ECG straight onto the iPhone. It's now in all the GP practices in northwest London. Big productivity gain for them, big productivity gain for the system, and way better quality care because it does a AI readout rather than a human eyes readout.
No, that's So it's good. It's good to see your enthusiasm for that, and I think that thank you for praising what's going on in North West London. It's very, very exciting. I'm going to ask a completely different last question. We've been here. We've bombarded you with questions. Short question, and some of them are tougher and some of them are easier. But we've also worked together, and I can see that I felt sometimes very frustrated at some of the things that have happened in the local NHS. I think you shared that at times. It's going to be quite challenging being the head of the whole system, and there's going to be a lot of frustrations about how the system operates and some of the people and whether it's vested interests or stick in the muds or whatever they are. How do you think you'll deal with the frustrations that you'll experience as the chair of NHS England?
So I'd like to say there's a wonderful thing about getting to a certain age in life when you can, when I was even more of a zealot when I was younger, but that's another story. But I think I am, I've learned a lot through the years. I like to believe I'm balanced. I certainly had an opportunity today, but I've become a good listener. I'm actually quite quiet a lot of the time, which isn't my natural style, so I've become much better at listening. I really try and hear different perspectives, really try and understand where different people are coming from. Absolutely recognise, I mean, people don't take positions on things just, well, occasionally they do, but in general, you know, not just because they've woken up that morning and decided to. There's usually very, very, very valid reasons behind many interests that people take. So I think really understanding those, listening to those and so on is a crucial thing. I think remembering the North Star, what are we all here for? We're here for the population. We haven't spoken much about inequalities, but you know, it's a key one. How do we improve things for everybody? And then, you know, keeping hold of that someone somewhere is doing something fantastic. And if we can take that and spread that, that is the hope. That is the bit that keeps me, it gives me hope and keeps me energised and keeps me going. And ultimately, that is my role. My role isn't to be there and be frustrated. My role is to keep going.
Thank you very much.
Thank you very much. Right, I've got just a couple of rounding off questions. We could have very well ended there. It was a good place to end. But I've just got a couple of points I need to touch on. Workforce.
Yes.
Has been a bit missing, actually, from our conversation thus
yes.
far. I wondered if you wanted to perhaps give us your thoughts on the importance of the NHS workforce, and in particular the workforce plan, and how it might need to change in the context of the big ambitions that we all share.
Yeah. So I was actually about to say, to Ben's question, the other thing is, I'm not by myself. I'm not going to be working by myself. There's 1.5 million employees. There's any number of people in local authorities, voluntary sector, private sector. You know, this is a very, very big world, and I think there's a bit about both drawing support from all those people as well as working with people. So in terms of workforce, I put that down. At the moment, there are challenges around to a degree, and in some places, I don't think everywhere, there is some disillusionment, there is frustration, there is change fatigue, and so on and so forth. So I come back to that word hope. I think it's a good word. And I think a bit about getting more of that out there. I think some of the things in the Gordon Messenger, Linda Pollard review about different management styles, I think that needs looking at, and so on and so forth. I think there's a big thing around more development opportunities for people, much better, you know, appraisals happen, but I don't see appraisals happening the way I'd like to see them happening, which is really helping understand what does someone want to do, where do they want to go to, and helping them on that journey, providing support to do that. So I think there's a lot of things around the workforce offer that could be developed and could change, and I'd like to see that, and again that comes back to the bit of hope. In terms of the workforce plan, so I believe that is due for a refresh. I think it's this summer, if I'm correct, and I believe that there is a commitment coming out of the 10-year plan to do that refresh, and I will take a very active interest in that. I'm very interested to see that that's done well. Yeah.
Thank you very much. And you spoke about development, personal development. Yeah. Well, the next steps are that we get to write a report about this, which turns around in very short shrift.
Yep.
What are the developmental points that you need in your role as chair? You mentioned working with the sheer complexity and scale of the whole NHS and central government was an area that you want to develop. Expand on that. What do you need to help us help you succeed?
Well, I mean, first off, you've asked the spot-on questions.
Thank you.
I agree with all of your questions. I mean, this is hard. So support, to be honest, is a big one.
What does that look like for you?
Constructive dialogue. I mean, challenging and constructive. So it has been a bit one way. There is some, we could have some other conversations. I come back to a bit what Ben was pushing me on this bit. I think there are choices. They're not easy choices because they're really hard choices. And I would hope, and so to a degree commit, or maybe promising too much, that we can get more of that data and analysis and so on, and be clear on what does that mean for the hard choices. So I think that's another bit. I recognise the primacy of Parliament and all of the MPs and everything else, and the balance, between representing your constituencies and so on and so forth. But there is a bit about almost having that shared view of what are the choices here, what are the challenges, what are the choices, and that for me is quite a key thing. that will be required, whether it's NHS England level, Department of Health and Social Care level, with the ministers and with the wider Parliament, being very clear on what are the choices facing. I think that's a big thing. Yeah. And then
so a bit about data. You spoke earlier about going out and learning more about local authorities and seeing more around the country. There's a tension there, of course, between the learning and the doing.
Yes.
How are you going to find that? Yes, this is a 2-3 days a week job, but that's a lot. I mean, in terms of your time commitment and getting going, can you envisage what that looks like in the next few months?
Yeah, I mean, I put that a bit in the questionnaire because at first I said I'll do a listening exercise, and I thought, oh my goodness, no, people are going to think she's going to be doing this listening exercise for the next 3 years, and you want me to do something. So so I think you can parallel process, by the way. So I definitely think that there's a lot that needs to happen. I think some of that needs to happen very quickly. You've alluded to some of the things, but 10-year plan will hopefully come out, and hopefully that will give a clear sense of direction, turning that into real tangible things, getting going on day one, keeping the show on the road. I mean, we haven't really spoken about that. In-year stability is a really big thing. People starting to use the word turnaround. I think that's probably a reasonable term to use. So it's a mixture here about keeping things going in the immediate, building that very clear plans for the future that take the 10-year plan and say, what does this mean? What are we going to do? Getting out around the country and seeing what people are doing, both as a listening but also sharing some of these things. So I think I'm going to be kept very busy from the 1st of April in doing those 3 things.
I suspect you may be. That's as good a place as any to end. Thank you very much, Dr. Penny Dash, for joining us this morning. Order.
Thanks very much.
Thank you.